Hi, everyone. Look at
Hey,
this
Cara.
extraordinary group here on time. Not a moment late. Nice to see you all. And I think we wanted to kick it off. Is Kellen here? Yeah, Kellen, would you like to kick it off with an announcement?
I would love to. Thank you. I'm Kellen. I'm a neuromuscular neurologist at the University of Michigan and part of the research committee in the INPCS group, and wanted to put a big plug in for the INPCS abstract submission for the annual meeting this fall. The deadline's mid-June, and we invite anybody and everybody to submit, including works in progress, QI. This is a great place to share ongoing and completed science. So I'll put the link in the chat and then I'll send out a follow-up email afterwards. But please, 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 we would love to see what everybody's been doing.
That's
Thank you.
awesome. Thank you, Kellen. It's also a great time to register for INPCS if you're able to go. So last couple days of September into October of this year. So September 29th through October 1st in Indianapolis. We're going to do a pre-conference focused on palliative care for ALS. Share both an update on projects that are going on in that space and have sort of conversation together about how we can best collaborate, directions we'd like to move together. So we would love to have you participate in that half-day pre-conference if you're interested. Other announcements?
Kara, is that on the Monday before the conference starts or
I think
Tuesday
it's on
morning?
Tuesday.
Okay, perfect.
Tuesday, and I believe it's 10 to noon, our pre-conference. Thanks for asking. Um, great. Other announcements people would like to share?
Cara, would it be okay if I shared my URL?
Yes,
Okay, great.
please go right ahead.
Hi everyone, I'm Christy Lero. I'm a PhD candidate at WashU in St. Louis, and I am, excuse the nasally sounding, I've got some sort of summer head cold, which we all love. But I have launched a survey specifically geared towards caregivers of people living with ALS, and I will put the links in the chat. There is a spot where you can go on the CDC website for it. And then I have a study website as well that will connect you to the survey. It's specifically for caregivers of people living with ALS. And I'm looking at caregiver role strain and well-being and how self-compassion might mediate that relationship. So please share widely.
Really look forward to hearing about your work as it evolves, Christy. It's very exciting. Awesome. So I'm going to transition us to the topic. Oh, and Umbreen, do you want to make an announcement about the psilocybin, or do you think this
Oh, sure. Yeah, just the
note makes
info's
sense?
there in case
Mhm.
people have interested participants. We're still open, enrolling. Only need 19 more, so we're getting close. Yeah. So hopefully that encourages people to, it's like when you only have five, bracelets left, you have to buy them before they're sold out. Um, and then I'm also just gonna put a reminder here that of the website that we made, our palliative care resources, for people to share with their colleagues or their patients and families, because it's already up and going. So there you go. Thanks, Cara.
Awesome. Awesome. So we're hoping to spend the rest of this time, and I want to give Astrid actually a little shout out for in part motivating this conversation and bringing up this idea. But we wanted to talk about practice delivery models for palliative care for ALS. And I put a few initial questions in the chat that I was hoping that we can talk through in a open, free format here. But we'd love to hear, who you are and where you practice and then also, what care model do you use or is used at your institution? If you're an ALS clinician, we're interested in hearing kind of what care models of palliative care do you refer people to or provide through your team, and which palliative care clinicians see patients and or are available to patients. What are the advantages of that care delivery models, palliative care delivery model for this population? What are disadvantages and what are sort of barriers to providing what you might see as an ideal care model. I've got more questions after that, but I thought that might be a good place to start. And I'm hoping we can kind of aggregate these ideas primarily for quality improvement purposes and distribute them throughout our group and perhaps beyond. So if you're interested in reviewing the recording from this and other focus groups that we're doing on this topic, and helping to aggregate key themes, I'd be delighted to work with any of you on this. So I'll just put that out there. But let's open it up to the group if you're willing to share. And, I was thinking about clinicians in having this conversation, but if you have, if you're not a ALS or palliative care clinician, but have perspectives to share, I welcome those as well.
I'm happy to open since you threw my name into the mix, if that's cool. So
Please.
thank you so much for talking about this. I'm a palliative care clinician. For those of us that have not met, I am not like neuromuscular trained or anything. Most of my practice is actually in the inpatient setting. I'm on the general palliative care service. And so anytime somebody with ALS is admitted to our hospital, I get a consult. We've kind of tried to train all of like a multiple of our staff to recognize they have ALS, they've had a hospitalization, they should see palliative care. And then I'm also integrated into the multidisciplinary clinic at Baylor, which means that when people come for their multidisciplinary visit, I'm one of the anywhere from like 5 to a dozen people that they might see in a single visit. We do not have any kind of like outpatient palliative care practice here. So sometimes I'll do like an extra visit, like a televisit, but I'm taking time away from the inpatient service to be able to do that. So that's been incredibly challenging because people get so overwhelmed, I think, with the 5 to 12 people they already see. And once every 3 months, and that's been really challenging for I think our practice and kind of what I'm able to provide in a single day. So I'm really excited to hear what other people do, and kind of how they tackle this, especially with a small team. I have no support services outside of what the ALS clinic has. So.
Thanks, Astrid. Can everyone hear me? Okay. I think you bring up a lot of good points, and I'm just kind of curious how everyone's building their clinics. I'm fully asynchronous, as some of you know, so ALS clinic refers to me. I think I asked them about their practice patterns. They're like, has ALS? So I think if we're thinking about like needs-based versus disease-based, I actually don't know why they refer to me. I know there have been, screening tools utilized in other neurodegenerative diseases in the past to see who might have higher palliative needs. We don't really do that. I'm almost fully telehealth, which has its, upsides and downsides. They often do come to see me because it's easier. I don't do it on the same day as ALS clinic, but I think the rapport and the connection are just so different when you're seeing them almost exclusively via telehealth. There's a lot of communication back and forth between visits. So I kind of pitch it as, instead of, 4 visits a year with the ALS team, you get 8 a year because I see them about every 3 months as well. And we can kind of catch things and communicate back and forth. And then I think those are kind of the big things that I wanted to think on a little bit. I actually wanted to hop in because I see Gabriella Mead, one of our PhD speech language pathologists who's actually integrated in the clinic. So I don't know if I've actually asked folks what it feels like for me to be completely asynchronous and how that, how I feel rather disconnected. I don't know if they're feeling that on their side as well.
I don't feel disconnected, but we talk quite a bit. So I can't speak for the other members of the team. What I will say is that I think it's nice that there definitely are benefits to not having you in clinic because I think needs arise in the interim between the 3-month clinics that we have, and that you're often able to catch those and or report on changes that have happened in that interim, which allows us to follow up. So I actually like reading your notes on what has happened in the interim since the last clinic visit, as opposed to having you integrated and at the same time points as we're seeing them. I don't know what the referral practice is, who gets referred to you and who doesn't. I thought it was everybody.
It feels like it. That's okay.
Yeah, I think my understanding was that it was everybody
Okay.
who was willing to see you. But I'm not sure if that's formalized or who is the one who's doing the referrals.
Yeah, I think it's usually the neurologist. Maybe they just have an understanding that I think you're right. If they're willing, they see me. I will add too, I can try to pop by if it feels like, hey, this person never has their caregiver on their telehealth visit because they just kind of are like, oh yeah, that's, they're just going to do their thing. Then I may say like, we might have to have a serious conversation. I'll see if I can align and pop by ALS clinic to try to put a face to a name. Again, I know I have like a limited period of time. I ask permission. I try to coordinate with everyone else. So there is some ability to pop in person.
And Claudia, sorry if I missed this, but um, in palliative medicine, you're the sole clinician, so you're the physician, and you work with psychosocial members of the ALS team for psychosocial needs, like a social worker on the ALS team. Is that right? Um,
I'm not the neurologist in ALS clinic. They've got
right.
their true neuromuscular neurologist.
Yep.
I'm like the palliative clinician, and I
Mhm.
think maybe separate from or different than some of you. Anyone on our team can see anyone. So I actually have a challenging, just a complex patient who's coming back in clinic on a day that I'm not there. So I was like, okay, looked at the list of clinicians. One of my physician colleagues actually has happened to piggyback on a lot of my ALS patients. I'm like, okay, here, Molly, here's the situation. Here's why you need to see them in person. Like, I would really
Mhm.
like them to see you. And so it does help to have other physician support. Usually it's the physicians who feel more comfortable than neuro patients than our APCs, just kind of the way our practice is. And then we've got a lot of psychosocial support built into our palliative clinic as well that the ALS patients can draw from.
Oh, that's great.
So
And who are
yeah,
those
we have a
clinicians?
social
Okay.
worker in clinic who sees all of the patients, but tends to focus more on resource oriented care. And then we've also expanded are offering meaning-centered psychotherapy and dignity therapy to a lot of our ALS patients, which I think has been a huge practice change and really beneficial.
That's amazing. Can you tell us a little bit more about that? Is that the ALS social worker who runs those? Are they groups or?
Claudia can maybe speak to it.
Okay.
It's the palliative social worker
Hmm.
and palliative physicians who are
Mhm.
running the group. It is in group, and it tends to be a mixed group with people with ALS, MSA, other neurodegenerative diseases, and also cancer at this point, just based on who signs up, from how I understand it,
Hmm.
Claudia.
Yeah.
Um,
We've got social workers, like one of our physician, actually one social worker, one physician, actually one of our NPs who are trained in meaning-centered psychotherapy. And so they have a group. It's like 8 sessions. So every 2 months, there's a new group, maybe like 5 or 6 or something, patients. And then they recently started caregivers as well, are a separate group. And so that, Deco Gabriella has been really helpful for folks. We have dignity therapy or like legacy work, which also has been wonderful for our patients with ALS. And then we actually have music therapy, which oddly enough has really taken off as well. Patients who maybe can't speak or can't move as well. When I patients with ALS was like, it hasn't taken away my hearing. So I can still enjoy music and find ways to think of that as a source of coping.
I
That's
will
awesome.
make a plug to, I'm really interested in some of the psychosocial supports and how they are effective or not for people who have dysarthria or other progressive motor speech disorders, and how we can work to accommodate their needs in that context too, if anybody else is interested in those topics.
Awesome. Yeah, that Gabriella, we have a couple speech language pathologists who are particularly interested in doing work in this area. So if you want to email me, I'm happy to connect you with them.
Yeah, I think you connected me with
Oh,
Christy,
okay. Perfect,
which
perfect.
is perfect. So we're going
Okay,
to meet in a week or two and talk about the panel.
great. Um, and Claudia, can I ask you on the palliative care team, do you normally see patients independently, like as the physician with the patient and family, or do you see them patients along with the social worker or other clinicians from the palliative care team?
Almost exclusively by myself. If there's, significant needs or some reason to pull them in, I'll pull them in. I guess we haven't done a lot of combined virtual visits with kind of like this, multiple people talking together. But certainly in our clinic setting for patients with cancer and otherwise, if it feels like, there's a big portion of like coping that's happening, and then we're doing some of the medical bit, it probably makes sense to bring the social worker or chaplain, sometimes even in along with the clinician, and then we both kind of do it all together in a more integrated fashion.
Fantastic. people from other centers that like to share about how your care delivery model works?
I can go. Can you guys hear me okay?
Yep, sure can.
Okay, awesome. So sorry that I'm not on camera. I'm Carolyn. I'm a neuropalliative physician at Mount Sinai in New York. And I've been embedded in our ALS clinic since 2019-ish. I currently only do like 17 Mondays a year, kind of a weird schedule. But even though it's every Monday. And when I'm there, I see everybody with the social worker. It's kind of an opt out. So I'm like in the mix with everybody else, sort of similar to what Astrid described. And so I don't think they're never really seeing a dozen people, which I think probably helps. And I think I like seeing people with the social worker because if they have any sort of apprehension about palliative care and are thinking about end of life care, it really helps to sort of talk first about their social work needs, for example. So that has, I think, worked pretty well for us. Um, Challenges maybe would be, I mean, I think one obviously just for us is that I'm not there all the time, but usually we just either have them, if somebody needs palliative care, then they'll see me separately in my other outpatient clinic, or we'll set up a telehealth visit for them when I'm in ALS clinic, just not on their regular ALS clinic day. And then I think the other thing that is a little bit tricky is that my practice when I'm physically in a clinic is almost exclusively like serious illness conversations because they're seeing their neuromuscular neurologist on the same day. And I think they, with some variability, we have three now, prefer to do symptom management. Every now and again, there will be something where I'll have a suggestion and they'll actually agree with it. But for the most part, I've sort of stopped doing a lot of symptom management unless it's like a scenario where somebody really needs like they have such severe refractory pain that we're starting opioids, then I'll do it.
Mhm.
Um,
Could
yeah,
I
so I
ask
think
you more
that's
about those serious illness conversations and sort of how you
oh yeah.
provide those with the neuromuscular neurologists? Like, are those conversations
Um,
about PEG, trach, or other things, or hospice, end of life care?
Yeah, great question. I would say it's more commonly me bringing up those topics because I think a big part of the, if I may say, benefit of having me there is that people have earlier conversations about things. It's not as much like we're kind of waiting until it's like imminent. So like if someone's starting to have dysphagia, I'll start to have a conversation like anticipatory guidance about PEG. If someone is starting NIV, then I'll have, some conversations about like what that means and what they can expect. And so that way it's like sort of bit by bit. So I would say like early when I see people, like if it's a diagnostic, or they've already been diagnosed always, but like if it's their first visit to ALS clinic, we're usually focused more on kind of like building rapport, getting a sense of what their information preferences are, kind of talking about coping, and we'll check in with them about that longitudinally. But then we'll also, like I said, if they're sort of starting to have these other symptoms, then then we'll sort of start doing some anticipatory guidance. And it seems to work out pretty well because they also see obviously a respiratory therapist and a speech pathologist and a nutritionist. So those people, in addition to their neurologist, could and do bring those topics up, but they're less likely to do so before it's like time to refer
Hmm.
for the procedure. So I think that's generally worked out pretty well. And they're pretty brief visits, like 30-ish minutes unless something crazy happens. And so um that's also sort of a nice way to just build over time. Because it's like, well, today
Hmm.
we're just giving you a heads up that this is something that's going to come up down the road.
Yeah. And so, Carolyn, you see most of your patients in person then, because they're coming to the.
Yeah, I would say so. I mean, we have a fair amount of telehealth uh, folks anyway, like
Okay.
people who it's just very hard
Able
to
to
leave
move.
home. And so,
Mhm.
um, but yeah, I would say generally in person, but with those exceptions that like if I wasn't there on the day they were there, but they have sort of more urgent palliative care needs, then we'll arrange a telehealth appointment just because it's too
Mhm.
hard to find a room. Um, or usually if I'm seeing them in my like separate outpatient clinic, I will also see them via telehealth just so it's not another trip that they have to make.
Makes sense. And on the palliative care side of things, do you have other palliative care clinicians who see patients with ALS frequently or generally not?
Not in that clinic. So the Bronx VA has an ALS clinic with a Mount Sinai palliative physician. I used to be Elizabeth Lindenberger. I'm sure many folks know her. Since she has left Sinai, there was like a gap for a little bit, and now it's someone else who I'm embarrassed to say I don't know his name. I don't recall his name. Sorry.
All good.
If you're in the group today, we should meet sometime.
Sounds good. So for psychosocial needs, it sounds like you support people around some of that and probably refer to the ALS social worker or others
Yeah.
as well. Okay. And Steve had a question. Do you negotiate with the ALS teams which issues you need to discuss? Like today, we need to um, discuss PEG or NIV or mechanical ventilation.
That's a great question. I would say generally no. If there's something that comes up that's sort of unexpected, then I'll like flag someone down in the hall. I pretty much always try not to be the first person somebody sees unless it's like we know each other, they know who I am, and like they really want to have serious illness conversations, which is certainly, some people. But yeah, and then usually I'll kind of check in with like the respiratory therapist or the speech pathologist if
Mhm.
they've already seen the person before I go in. And so that way I have some sense of like, what did they bring up? And also, what are they noticing?
Yeah.
Rather than kind of starting fresh. Pretty rare that I am talking to the neuromuscular folks before I see the patient again, unless there's like some complicated thing. Or sometimes if they think someone should do a most, then they'll say, "Oh, hey, could you do that?" And then I see Claudia's question, um, urgent goals of care needs. Yeah, I guess that's how I would. Um, that's when I would do an extra visit.
So that message might come in through the neuromuscular neurologist, like we're worried about this person, or it might come from a patient or family through the
Yes.
EHR, like there seems to be a decline, and then you might add on that visit.
Yeah, I would say it happens a lot initiated by patients or caregivers.
hmm
Um, yeah.
And it sounds like you kind of, to Steve's question, like you already have sort of worked out with the neuromuscular neurologists a fair sense of like this is what I'm going to cover, so that you don't have to talk to them
Yeah.
about it for each case. It's like they trust you to sort of cover the topics in appropriate timeline. And you
Yeah, I
sounds
would.
like trust them to cover most of the symptoms as needed.
Yeah, I would say so. I mean, I definitely will still ask about symptoms,
hmm
but generally kind of let them manage it unless it's something that's like pretty clearly in my wheelhouse.
hmm
Um, and then yeah, I think at this point, like I think initially I was a little more cautious because I really felt like I needed to build rapport with the team. And so I might like get more input from them, but I think they appreciate that I'm not. Well, I think for one thing, they appreciate that now they don't have to have the conversations as much, or it's like they're not as kind of coming out of left field, maybe. Um, but also that, that I am sort of more educating and that I'm not like, pushing people into discontinuing certain types of
hmm
interventions that they I think that is something that they would potentially be nervous about, but at this point they recognize that that's not what I do.
Yes. Did you guys sit down and talk about like division of labor? You do this, we're going to do this, or was it something that just more um, organically developed as you got
Um,
experience with
hmm.
each other?
Yeah, that's a great question. So I definitely sat down with them and talked about it, and I would say more so about the like serious illness conversations and kind of like allaying any concerns that they had. I think earlier, I think we didn't really divvy up the symptom management stuff as much. I mean, I think it was sort of touched on briefly, but it wasn't like, I really feel strongly that I would like to continue managing all the symptoms for my patients, but you could share some thoughts if you wanted to. I think it was more like it pretty quickly became, like I'd make suggestions and they'd be like, yeah, but what about this completely different thing? And I'd be like, sure. I realize that, been doing this for a long time and whatever. But at the same time, if I see people separately and I prescribe or make a recommendation, that's never a problem. So I think it's just here. I'm here, so like we're gonna do um,
Yes.
I'm the primary
Hmm.
person.
Beautiful. Of course, there's so much to ask on all of these, but let's keep opening it up to additional groups if you'd like to share how things work in your shop.
I'm happy to share. Oh,
Thanks.
sorry. I don't know
Please
if
do.
someone else was going to.
Go ahead, you
Oh,
go first, Monica.
sorry. Okay. Um, Hi, I'm Monica Zell. I'm a palliative care doc. I work at US Keck USC in down in LA. Um, I am internal medicine trained, and I really first kind of became very interested in palliative care for ALS in my fellowship. I had several kind of meaningful, eye-opening encounters and experiences that really kind of, you know, piqued my interest. And then when I was taking my job at USC, and our palliative care program was kind of in a state of transition. A few of the docs who were there and would see ALS patients kind of intermittently, just from kind of uh, through the channel of like a normal kind of placing a referral for palliative care for an outpatient appointment. That was kind of the state of palliative care's involvement with the ALS clinic before. I don't believe that the prior physicians were integrated in the clinic. And so I kind of just inserted myself. I reached out to the to the clinic and said, "Hey, I'm here. I would love to be involved." And I kind of just became involved in part of the ALS multidisciplinary clinic now in my fourth year. And I really like my setup in terms of I am asynchronous in that I have two neuropalliative care clinics. I'm basically half of my outpatient time is for cancer clinics and half is neuro clinics. Um, and I don't just see ALS patients, I see different neurologic patients with different neurologic conditions too. But a lot of my neuro clinics are dedicated to ALS patient visits. Um, and so I do like the asynchronous kind of having a more staggered multiple touch points approach. And it allows me, I'm someone who just, you know, I need more time. I need time and space with people. And I feel like I would struggle with the fast pace of the multidisciplinary clinic model. Um, Even though I recognize its benefit as well, but I do like having my own kind of, and it allows me to really have a sense of not ownership, but real continuity in my own personal relationship with these patients and families. And they feel, in some cases, that I'm just as much a kind of their ALS provider as much as their ALS team. But I also, because I want to have a really good relationship and a open channels of communication and trust with the ALS multidisciplinary team, I have carved out of my schedule that I go to their post multidisciplinary clinic meetings as much as I can. And that's really on my own time. I go, and that's every 2 weeks, usually for several hours, whether it's virtual or in person. I try to be present And they look to me, during those meetings of, do I already know this person? They, as they're going around for the multidisciplinary clinic, I contribute my piece then. And if I don't know the patients, they look to me to say, do you think this would be a reasonable referral? They're having these symptoms. Can you see them? So there's a really nice trust at this point and kind of open communication that I really value. I find this to be like my probably most meaningful part of my work. Um, and so I feel like it's meaningful enough that I'm willing to spend time that is not billable going to these meetings. And then it really allows me, I'm in our Teams chat I'm constantly messaging them, hey, this is what I'm hearing from them. Can we help submit these DME orders, or they need a wheelchair evaluation, or they need a speech, so I'm very frequently in contact with the team outside of clinic, and then I'm often in touch with patients and families outside of clinic, my clinic visits. Um, in terms of kind of, I would say they do look to me a lot for symptom management, but then they also look to me a lot for the big kind of crossroads decisions and conversations. Um, and I would say that since I've started, our, degree of getting people enrolled in hospice and doing more advanced care planning has changed significantly. Um, and there was something that someone mentioned that I was going to comment on. In terms of kind of like the urgent needs, I do try to be accommodating. Like I got a message yesterday that one of our patients is, called in, you know, with difficulty breathing. They got triaged and now they're in an outside hospital. I'm planning to call the wife today to see, how's that going? What's happening? Follow up on our previous conversations where I kind of planted seeds that I was worried that this is not too far around the corner, and decisions were kind of really not yet made. So things like that, I'll either do, calls outside of clinic visits, or I'll arrange add-on visits if I really think that this needs like a sit-down conversation over telemed usually. Um, yeah, that's a good blurb.
That's great. So it sounds like Monica, even though you really value your relationship with the ALS team and have a close relationship, seeing people at a different time, and mostly via telemedicine has been worked better for you to see people when they need to be seen and to have a little bit more flexibility in your timing, for the visits. And
Yeah.
yeah.
And I would say that, I know one of the questions was about how much time we give. My new patient visits, I do for an hour, and often they're over an hour, especially if there's already communication impairments or language barriers, technologic issues over telemed. So having the hour really works. And then actually I've been able to, and I'm grateful that my team and my institution is supporting this. I've actually asked for I have established that 30 minutes for a follow-up visit for a lot of these patients, especially in the more advanced stages, is just not sufficient. So I'm now doing 40 minutes for follow-up visits,
Nice.
for my neuro patients. Yeah.
When you see people in palliative care, do you have other palliative care clinicians that see the patients with you or that are available to you? No.
Nope.
Okay.
I am my own palliative care multidisciplinary team.
Mhm.
There is a social worker uh, who is, part of our ALS clinic, but she's also, unfortunately, due to, funding issues, she's not voluntary, but she's more peripheral than I would say some academic centers that probably have a very well integrated, active, social work presence. This social worker tries to be available for the virtual post-clinic meetings, but she really only meets with patients and families when referred, often for kind of some coping support and resources. Um, I know that there's been arrangements where like ALS Network can uh, use a grant to pay for like 5 sessions of kind of like psychotherapy sessions with her, through ALS Network funding that's kind of outside of clinic time. Um, and that's been an arrangement, but in terms of palliative care clinicians at USC, I'm the only one that's seeing ALS patients, and we unfortunately don't have a palliative care outpatient social worker at all for our cancer patients or my neuro clinics as well. So it's
Thanks. Couple questions from Steve about, are you able to see people with other illnesses like lung or cardiac disease during your neuropalliative care clinic, or do you feel like the relationship with the ALS team is different than the relationship you have with other referring teams?
definitely, I think that uh, it, there is now this because it's only been a few years, but I think just the continuity and the trust that's built with the same faces being part of this and them seeing that I show up, am responsive. I really view myself as part of the team. I think that relationship in terms with collaborators, I would argue, is probably stronger than like, I have relationships with different oncologists and things like that are very strong. But I would say that I will say that I'm also part of like the movement disorder multidisciplinary clinic. But my role is, I don't view my role with that group as strong as with the ALS clinic. I'm kind of like, they refer to me and I try to go to their meetings, but this is really my primary kind of group that I really feel acceptance and welcoming and kind of partnership in.
Mm-hmm. And
Hey,
do you see people
Monica, sorry, can I
Yeah.
follow up on that? Um, like, is it a funding issue or why is it like a neuropalliative care clinic as opposed to like anything else? Does the funding come through neurology? And it sounds like you're the only doctor who sees like could another outpatient doctor see a patient with ALS, or like how did that relationship come to be so
Yeah.
specific?
Probably because our outpatient palliative care presence has really gone from 0 to 60 in just a few years ago. In just a few years, we basically had very little outpatient palliative care, and primarily it was cancer based. I really kind of said, I'm going to be the neuro person because we didn't have anyone else. And so I have built my own practice in neuropalliative care. And then now we have my colleague who is also split now. I think he's going to be more of we're trying to do kind of a more division of labor where he's going to be more of our organ dysfunction failure outpatient provider for the non-cancer clinics. And then he also has a cancer clinic. And then we have a couple people who just see cancer patients. But from the non-cancer clinics, myself, I kind of take the neuro patients. If there's people I can't see in time, a lot of things like, memory or dementia patients, if I really can't fit them in, if I'm so booked out, that is someone I can trust. And I know my colleague will see, but I do have this kind of selfish ownership over the ALS patients where it's like at this point I'm just so well established with them. It's just easier for everyone involved, I think, for me to be the one that they see. But then it's nice now that we have someone else who can see these other um, groups of serious illnesses in the outpatient setting. I don't know if hopefully that answers your question. Yeah.
I see that David's hand is up. Do you want to?
Yeah, to Steve's point a little bit, I thought that was an interesting question from you in terms of whether it should be a neuropalliative care clinic or not. One of the things, and of course, you know that my predominant practice is in pediatric hospice and palliative care, and when I was program director at Children's National of Washington, D.C., we developed our program to embed one of the palliative care clinicians in subspecialty clinics. So, for example, I would go to the white matter clinic, the kids who had genetic neurodegenerative conditions, for example, adrenal leukodystrophies and things like that you adult guys don't see. But I embedded myself in that clinic. One of our nurse practitioners, very experienced, embedded herself in the cardiac ICU. And
Mhm.
so we took on a specialty role even within the context of the general palliative care service. And
Mhm.
I think that what I heard Monica say was that there is something unique and special about this ALS population that's perhaps different from the movement disorder clinic. I mean, most of the movement disorders may not be as rapidly progressive as ALS, where I think the average time to death after diagnosis is just 5 years. And so I think that having a dedicated person with comfort and expertise, rapport with the neuromuscular disease team, I think is very valuable because we in palliative care are not only focusing on the patient and the family, but we're also focused on the subspecialty other providers who may not be as comfortable as we are with death and terminal illness and end stage symptom management. So I think that it's very valuable to specialize, so to speak, in those unique areas where the trajectory to mortality is pretty well defined.
Thank you, David. I totally agree. I'm a huge proponent of specialty aligned palliative care, if you want to call it that, or having embedded programs specific to a patient population. And I think there's a lot of advantages. Great. Additional teams you'd like to share? I know, Umbreen, you were going to share. Do you want to?
Sure, yeah. I didn't
Yolanda?
want to, I know a lot of people have, I've talked to a lot of people about this, so I didn't want to kind of duplicate, but I was going to comment that there's so many overlaps, like things from what Monica shared to what Carolyn
Mhm.
does. And I'm at Hopkins. We're having some changes in our clinics, but we have two ALS clinics, um, primarily because of overflow, and one's funded by MDA and one's funded by ALSA. And MDA started many, many years ago, so they actually didn't have, I'll just put it out there, they didn't have interest in me joining their group because they said they, in the very traditional model, take care of the patients themselves and they don't really need a palliative specialist. But they opened the second clinic in 2021, and which is around the time I joined faculty there in 2020. So it took whatever time it was to set up. And so I joined them from the beginning, um, but joined them with my academic time. So the way Hopkins sets itself up is because I am contracted with one hospital on one site and this clinic is on another site, uh, it doesn't reimburse to my department. So if people need to talk with me about that, like, and that's helpful to you, that's fine. I don't think it necessarily answers the questions we need to, but all to say that it is basically, I staff out of my academic time for that clinic, which is twice a month, all day, and it's embedded. And over the years, and very similar to kind of what other people have described, of basically most of the work that I end up doing is the goals of care conversations and kind of therapeutic work. And similar to others, it's just me, the one-man band for all of like palliative. So no psychiatrist, no psychologist, no therapist, no, we have a social worker, but that the social worker is from the ALSA. And so we don't have
Mhm.
we don't have an additional social worker for either logistics or therapy. Um, and then I do join at the end of the day, the team meeting, to discuss all the patient care. Um, I've been increasingly doing virtual visits, and that is becoming something that I'm been curious and listening for how people handle that, because um, it's been up until now, I've been able to kind of intersperse them with whoever I see. And the way we do it is the nurse practitioner is I had to teach them, to your earlier question, Karav, I kind of had to teach them what I do. And then the nurse practitioner like introduces it and then kind of sends me is very open to sending me lots of referrals. Um, and because I'm sitting in the team room, people are like, oh, there's lots of distress in that room. Can you go see them? And so because I don't need a referral, I can basically walk in to see any person who comes into that space. So that makes it easy. And we learned from one of our studies that the patients and care partners didn't want us to almost like triage for them. Like they wanted like me to just come and see them and tell them what I do, and then they would decide if they want to see me that day or not. So that way, it's kind of a nice way to just kind of get in the door without having to worry about triaging or triggers. Um, but what I've been kind of trying to figure out recently is the virtual visits have been increasing, especially because I can't staff the second clinic. And our nurse practitioner is now staffing that second clinic, has a lot of referrals. And so I'm finding that half the day or a full day could be easily filled. The advantage of being in the clinic physically and then kind of running in to go see a virtual patient in between real life patients was that I saw a lot of real life patients and then, a few virtual, but then sometimes I would run over with an in-person, or the virtual would be late or not show up until
Challenging.
so it's very
Logistically.
standard virtual real life integration issues. And now there's enough that like I could be separated out, and so I could like basically do an entire day of virtual visits, but then I would lose that beautiful integration. So, but I would also be able to serve more patients. So it's a little bit of that balance that I'm trying to figure out.
Yeah, in response to Steve's question here, do folks who are embedded in the ALS team clinic feel that that's a good use of their time, that the needs of the patients and your time are well matched? Or does it sometimes feel like the needs of the patients and your time aren't well aligned when you're, showing up to the multidisciplinary ALS clinic and seeing patients in that setting rather than scheduling the patients who you think you need to see you at the time that you want to see them?
I mean, I think so. I am biased because I'm not built to be an outpatient provider to see 20 patients a day. Like I'm just not built for that. That's like I'm really bad at that actually. And so
No
when I
one
have
should see
like
20
seven
patients in a day. I'm gonna throw that
yeah,
out
like
there
when I
in
get
our
to like
specialty.
8, I'm like, oh my
Yeah.
God, I'm so tired. I don't know how to do any more than this. And I think I
Yeah.
would cry if I had to. So I think for me, it feels valuable and good use, like a good use of my time, because otherwise, actually, the alternative is there isn't anybody. Yes, you're absolutely right. Nobody should see 20 patients a day, but like the inpatient, inpatients, if we range between 6 and 8, that's a full day. And these patients I've found, at least for myself, I'm also not very efficient, so I can't do a patient in 30 minutes. I just really struggle with that. I don't know how other people are also structuring their visits, but I find that like 45 minutes to an hour is kind of the range. And it's because every single person is a goals of care conversation or a deep conversation. And like others, I mean, I do symptom management, but most of the management is managed by the primary teams, and I get the symptoms that I get referred a lot for are insomnia, appetite, and depression and like mood. Those are like the one, and then those integrate so much into quality of life conversation. They're not simple, or not simple, but sometimes the pain assessments are a little bit more straightforward or quick. And so the conversations are 45 minutes to an hour each. And so I don't know. I think they're a good use of my time, but that's me. And I'm off. I'm going to mute myself now.
Awesome. And I'd love to hear from additional folks. And I wanted to offer that I can stay on beyond 10:30 Pacific if anyone wants to stay on for a few extra minutes and share, who hasn't gotten a chance to share, because I'd love to be able to catalog all these different experiences and sort of share them with folks in a summarized fashion. As long as that's okay with you, let me know if anyone doesn't want their experiences shared in aggregate.
I'll agree with Umbreen that my experience being integrated into the multidisciplinary clinic has been a positive one because much like Umbrine, I'm quickly able to be pulled into cases where there's unexpected distress and we need to really talk about it the same day. Um, but I've also found that, like I said, it can be just such a busy and overwhelming day for people that
Hmm.
diving into some of those topics in detail is challenging. So I've envisioned that like my ideal practice would be kind of a blend between the two, going to the clinics, but having the flexibility to see some of these patients asynchronously when there's something that's less urgent that needs to be addressed.
Hmm.
Um,
Awesome. Farah, thank you for putting your comments in the chat about which people are with ALS really benefit or need specialized palliative care in addition to the multidisciplinary ALS team. I welcome other people's thoughts on that. And can I call you out, Farah, and get you to share a little bit about your model because you're working
Oh,
outside an academic institution? It might be valuable for us to hear from you.
yeah, for sure. Thank you. And I have to admit, like I was in another meeting and I'm only jumped into the last 15 minutes of this one because I hate
Oh,
to miss
okay.
it.
I
So
can
I
put the
missed the
questions
whole,
in the chat again. Sorry. If you don't mind introducing, yourself and your discipline where you
yes.
work, and then the model of palliative care that you provide to people with ALS
Okay.
specifically,
Yes.
that'd be great.
So um I'm Farah Daly. I'm a neurologist by primary training. I subspecialized in palliative medicine. I'm in Northern Virginia,
Hmm.
and I have an independent mobile micro practice seeing people with neurological illness in their homes for specialized neuropalliative support. Um, let's see, were there more? What else was I supposed to say?
Yeah, so a little bit more about your care delivery model. It sounds like you, as the doctor, are the ones providing the palliative care. You don't have other clinicians on your team. Is
Yes,
that right? And
that's right. So,
you
yeah,
could say
go
a
ahead.
little bit about like how long you spend with people, how often you see them. It sounds like you're in the home, which is significant.
Okay.
Hmm.
Perfect. Yeah, so from a team perspective, I work completely independently. I'm by myself and I only represent the physician consultation element, though that's informed by 12 years of practice as a hospice medical director working with directly with chaplain and social work and visits. So I like to tell people that I provide economy level spiritual care and social support, get first class spiritual care and social support from someone specialized in those realms, but they I am addressing the whole person model basically,
Hmm.
and if the questions are of existential distress, then that's what I'm diving into with a person, and I'm trying to connect them to other resources. So I don't have my own team, but I actively connect with other team members in the community, and so there is an active network of independent private practitioner or private practice social workers specialized in caregiver support or grief support. And I actively collaborate with them. I actively collaborate with some spiritual care and um, as well as serious illness doulas and care managers, adult care managers, or
Hmm.
elder care managers. And I see my patients most commonly once a month. There are times where I will scale up and see someone every 2 weeks if they're really in distress. And there are times where I'm seeing someone quarterly if they have like a limb onset ALS and their needs are relatively slower and lower. Then
Hmm.
I might see those people quarterly or even twice a year. But I'm mostly being asked to get involved with people who have bulbar onset and who are declining rapidly. So I
Hmm.
will see them once a month or sometimes every 2 weeks. I stay there attending when they add hospice support. I stay as the attending of record. So I stay involved through that time and continue to make home visits once hospice is involved.
Hmm. Awesome. Thank you. Other questions for Farah and or other folks who'd like to share? Callan, would you like to share anything more about care delivery model where you are?
Sure. Um, So I think I mentioned I'm a neuromuscular neurologist, but I've sort of always had an
Mhm.
interest in palliative care, and trained with Darren Zoranic, so had good training. But my ALS clinic is at the VA, and our palliative care group is just swamped. And so
Mm,
referrals that were going to them were taking a long time to get in, or patients couldn't be seen frequently. Our clinic in and of itself is also overbooked, and so trying to get people into the clinic frequently was really challenging. And so I actually, with great support from like our service chief, they let me set up a separate virtual clinic, sort of specifically for me to run palliative care.
great.
Mostly it's goals of care conversations, a lot of mood management, and that if it's not full, because I do see all these people in clinic too, so sometimes I can do that there, but I'll often pull people, I think I put it into the chat, like the people who are always just sort of brushing off symptoms, even though I'm seeing their exam change, or, never like really, really want to participate in any type of research or something. And so I know that they're minimizing things to qualify. I will pull them into the separate clinic, and then they see me as like a different, like not the neurologist anymore, but somebody that they can talk to. And that tends to be helpful. But sometimes the virtual clinic doesn't fill. And so I've also sort of put in, um, I'm like the ALS veterans doc for the state and area. So I think somebody had a question about like getting VA connected. So a lot of times I am that person. And so I'll see people who are getting multidisciplinary care at a university clinic, and I'll just see them like every 6 months, 9 months, or if they need me more frequently for VA equipment. But a lot of that actually does turn into goals of care conversation just because the VA can provide so much extra support. Um, and then whatever, if there's not anything left there, but I did agree anything left over, I fill with general neurology virtual visits. It's like nothing related to anything, but there's always a surplus need. And so they fill those. But it's nice. There's some people who like Farah said, I've seen up to every 2 weeks. But most people, it's just sort of a one-time visit in between there every 3 months. And it's been fabulous. Our clinic social worker has a background in hospice palliative. And so we just sort of double team a lot of it, but everybody gets advanced directives filled out. Our hospitalizations have gone down. People really, really love it. Um, but again, it was a lot of flexibility that the VA let me have to do it. And then if there are, usually it's symptom management issues. I've sort of worked out a deal with our palliative group of like a SOS call. And so I put in the referral and they get people in urgently. Because at that point they know I've pretty much done everything I could, and really need some extra help.
So, Kellen, you said one-time consults. So you often will see people in the neuropalliative clinic just once, and then is that right? Or you'll see them a few times, or
So I'll see them a few times. Yeah.
okay.
So the people who don't want to follow in our multidisciplinary, like VA centered. So these are people usually who are in other ALS clinics, like at the University of Michigan or across the state. They'll come and they'll see me. Sometimes it's one time, but often it's like every 9 months because I will also help write for their DME and fill out what they need for like financial support and things like that, home care, caregiver support. But like the patients who we follow, I see as frequently as they need.
Cool. Cool. Oh my gosh, I know there's a lot of other people who might have a lot to share. Kelsey, do you want to share, or others who are eager to share? And again, I'm happy to stay on if a few more people want to share, though I realize some might need to go.
Blend of things too. Let's see. I'm family medicine and palliative care trained. Probably a number of you have heard this story at this point, but during my fellowship year in palliative medicine, I just was really drawn to neurodegenerative diseases in general, and I spent a lot of time shadowing neurologists. And at one point I Googled neuropalliative. I think I Googled like different combinations of neurology and palliative care, like to it's like, is this a thing that exists? And I was so excited to find the INPCS and like that this was something people were doing. And then subsequently connected with the ALS Working Group and all of you amazing people, especially Cara. um, I so towards the end of my fellowship year, I kind of got asked what I wanted to do. And at that time, we had our only outpatient palliative presence was in the cancer clinic. And I said, I really want to do neuropalliative care. And so my former program director and I branched out and started an outpatient clinic that was initially open to pulmonology referrals and neurology referrals, or because pulmonology had asked us specifically as well. Interestingly, at least half of my ALS referrals come through pulmonology as opposed to neurology now too. And so we ended up expanding a few months in, expanded to referrals from anyone. And so we are now the ambulatory palliative care clinic, the non-cancer clinic. So there's a huge variety of what we see there. That said, I'm like the informal neuropalliative specialist of our two, and Dr. Tepley sees more of the pulmonary fibrosis patients and respiratory diseases. On any given week, it's probably I do 3 half-day clinics a week. I have 60-minute initial appointments and 30-minute follow-ups, although I'm perpetually late. They're not really 30 minutes. And usually it's somewhere in the neighborhood of 60 to 70% are people with neurologic diagnoses. I had initially envisioned that I would see more people with ALS than I do. It was interesting to hear Monica talk about her relationship with the neuromuscular clinic as opposed to the movement disorders clinic. That's flipped for me. I have really close relationships with a lot of the movement disorders providers. I see a lot of PSP, MSA. I also get a lot of referrals from the ataxia clinic and Huntington's disease, and then a lot of just advanced Parkinson's disease. The ALS clinic, so interestingly, I have thought like, gosh, again, that traditional model of like, we're doing palliative care. I think it's challenging that like, as opposed to oncology, where there's obviously like a clear division and the oncologist can say like, yes, I'm doing this, I'm following this chemotherapy track and this is what I focus on, and maybe this was said before I signed on, but and there's an obvious like separate role for palliative. That gets really complicated with ALS because neurologists are doing a lot of symptom management, and in terms of like other domains in palliative care, I think that's kind of provider dependent. Yeah, I would say I'm inspired by hearing about some of the relationships you guys have with your multidisciplinary clinics. I have worried that like because I don't want to step on toes and I worry about overstepping. And honestly, the last time I signed on to the Department of Neuroscience meeting to talk about palliative care, which was the third time that I've done it in the past 18 months, one of the movement disorders providers was like, we have palliative care available to us.
Oh,
So
boy.
that was like a red flag to me that I clearly need to do a better job. I hate using this word, but like marketing and letting them know that we're available. Because it was well received, and I've since had some referrals from him too. So I think
Cool.
it's just kind of this like old habits die hard. Like,
Mhm.
so
Yes.
yeah, I do a ton of telehealth too.
Mhm. Cool. Cool, cool, cool. Not to cut you off, but I want to make sure if
Oh,
there's
it's
others
okay.
who want to share about your care delivery model. I think a lot of us are getting a lot of value out of this conversation. And if you haven't shared yet, feel free.
I was just gonna say hi briefly. My name's
Please.
Jen. I'm over at University of Michigan, Kellen. She's at the VA across the street, and so I did my palliative care fellowship after neurology residency at University of Rochester, and then I just moved back to Michigan to do some general neurology, and I started our subspecialty neuropalliative care clinic here. Another one-man show
Mm,
situation. We do, fortunately, because I'm actually in the palliative care department, dual appointment, so I do have access to like a care navigator,
mm,
nurse care navigator who services all the outpatient providers in palliative care. Um, and then we have the way that I've been doing with social work, because we have a geriatric social worker, but she like serves all the primary care geriatrics clinics plus palliative care, which is just a few of us staff.
ooh,
So it's
a
way
big
too much
job.
on her plate to really be integrated. So I've kind of built relationships with the social workers in the subspecialty clinics, like our ALS social worker, which we're fortunate to have. She's very readily available there. We have she also works with the MDA clinic, or the sorry, muscular dystrophy clinic as well. And then I have a relationship with a movement disorder social worker. So if I see someone of that subspecialty, I'll work with them directly. Um,
Mhm.
so I'm seeing a mix of diagnoses, and I do see general palliative patients right now as my clinic kind of builds. I just started in July. Um, but I was thinking
A range of people with neurologic illnesses or beyond that too.
beyond that, yeah. So most
Mhm.
right now, mostly it is patients with neurologic illness. But I have to, if it doesn't fill, they'll fill with new
Mhm.
patients who have, other general medicine
Mhm.
diagnoses. So um, I I came joined late, so I didn't get a chance to hear everyone, but I just wanted to say to Kelsey's point, like this idea of like marketing or advertising, I think I've been very like shy about. It's just like not,
Mm,
it's not something that I think I like thought too much about, but I think I need to because I notice my ALS patients, because I'm not embedded, are the ones that I think benefit the most from the
mm,
subspecialty support. They're the ones that I'm doing a lot of rapid titration of medications for, and um, I I feel like if I had maybe something written, some sort of pamphlet, some sort of communication around what palliative care service provides, whether it's for the providers or for that they can maybe directly hand to the patients. I'm still trying to figure out what that could look like, and I'm just curious, even just off this call, if people have
mhm.
marketing tools, as you may call it, or resources to uh,
Yeah.
share with the ALS team. I think they're very open to it. So
I'm happy to share some materials with you via email, Jen. And I wonder if we should have a follow-up conversation at some point about marketing of our services and how we all approach that.
yeah,
Might be
thank you.
interesting.
Great.
And it's probably not it's not a one pager, but there are a number of documents or like papers on our trade wing group. If you go to the trade wing group under resources, we compiled a bunch of things there a few years ago. And then the website that I developed that I have the link to in the chat, I can put it again. But it's specifically palliative care and hospice for people who have ALS from all of our kind of organizations that have well developed, and it's meant to be easy to access.
Thank you.
So thank you. Jen, other people who would like to share? Marinella or Teresa, for example. don't know if you're still there or had to step away.
I'm here. I'm like in
Oh,
awe to hear all the possible, all these
hey.
exceptional
Yeah.
people doing crazy, incredible things. Oh,
Hmm.
one of the thing that, first of all, I'm in spinal cord. I work at the VA. We have an ALS clinic. Our palliativist, actually, who usually attends, Andrew Johnston is not here today, but we have an interdisciplinary model where we see all the patient the same day, and Andrews see the patient with us. Usually see them last, most of the time with our psychologists. We also have a dedicated ALS psychologist, which is like a godsend.
That's awesome.
So they start from day one, and on day one the conversation maybe just say, hi, this is Dr. Johnston. I work with with the team. I wanna, this is what they do. I talk, we talk about a little bit about go care, but it's a very brief introduction. And then as the disease progresses, he takes much more time and spends more time with them. But I think the initial presentation, which is basically we don't even ask the patient, we just send him in. It's important, because then when things become rough and they take turn for the worse, then they know who he is and they know who he works for, what's his scope, and it's super helpful. So yeah, we're blessed. And then
Awesome.
yeah, that's in short.
So they get involved and see everybody.
Correct, every single time.
And it sounds like the focus of the palliative care clinician is mostly on advanced care planning. Is that right? Less
Correct,
so on
yes.
symptom management?
They indeed, that was what I think Andrew thought he was going to do. But since for a while we didn't have a palliativist, I'm an internist by trade, although I do spinal cord and ALS, so it's kind of crazy. But also the other internists on the team who see all the patients also, we're pretty good with symptom management. So we we don't need them, but we work together. We talk about the huddle, of course, about the patient and what to do, but we feel fairly confident that we can manage them also without him. So his role is a little more focused.
Yeah. And if a family is in crisis of any type, can the palliative care doc see them between the scheduled multidisciplinary ALS visits, or does that happen
They
there?
do. They see them in between. And again, we know our patient very well. So sometimes they see them by themselves, sometimes together. The last case, for example, we had was a difficult case because my presence actually was making things a little more difficult, because the family kept talking about alternative treatment when the patient is basically terminal ALS. So they kind of kicked me out of the room and they said, let me the expert talk with them, because so we can focus a little more about what is important to talk about now.
Yeah.
Yeah.
Cool.
Sure.
Very cool. And that palliative care clinician, we haven't talked a lot about billing, but presumably bills, right? In addition to you billing, I don't know.
Yeah. So it's productivity. So basically at the beginning, when he meets first the patient, we put actually a consult in, and then every time he has his own visit. So we have a multiple clinicians seeing the patient on the same day. So multiple visits on the same day. Yes.
Okay. Cool.
Sure.
Anyone else?
Tara, I just wanted to ask a follow-up question. I was thinking about the billing aspect as well, and I know that some clinics are hesitant to take on palliative care because of that. We don't want to bill for the same thing. And I wondered, something we can be thinking about as we move forward, but is that why so many palliative care docs are primarily focused on goals of care during clinic, so that it's really clear the neurologist is not going to be, so that the
Good
billing is a
question.
non-issue?
Yeah, I think that the fear about billing is probably more myth than reality, to be honest. I think people might worry that the billing's not going to work out, but I think a lot of the groups on this call have proven that it can work out. And certainly in our
I
own
agree,
center.
but it's the people who aren't here who I think are
That's
saying
true.
it's a problem.
Yeah, and I wonder if a lot of that is myth, maybe. But I know if you're seeing people of different specialties, so if you're seeing a neurologist and an internist who specializes in palliative medicine on the same day, that's no problem. You can bill for the same issues. If you're both internists, it might be a bit more tricky, but with time-based billing, I'm not sure that's a problem actually, if you're billing by time rather than problems, complexity. But we certainly don't worry about billing as a reason for why we should focus on one topic versus another. But at UCSF, the palliative care team does see patients on a different day than they see the ALS clinic, because we found that has seemed to add more value when we can see people at a different point in time and add more total touch points for the patient and family with the healthcare system. So that's just felt like it's been less redundant and added more value. And there's certainly no issues with the palliative care doctors discussing the same topics that the ALS clinician discussed on another time. Because some people need that extra attention on symptoms, and so sometimes it's all hands on deck. They need to kind of hear about it from the ALS doc and the palliative care doc, or maybe the palliative care doc's focusing a bit more on pain and the ALS doc is focusing a bit more on spasticity or something, even though those things, have a relationship. Or they need to hear about advanced care planning from the ALS doc and the palliative care doc to kind of add more time and perspectives on that topic. But does that help? Do you think that would be at all satisfying to those people who are coming to you with their concerns about billing, Lori? Or do you feel like, no, they're going to remain concerned?
I just think that there's probably room for education there.
Yes. I've talked to a lot of people who don't realize that palliative care clinicians can bill because they think we're maybe nurses or some other discipline. It's really interesting that they think that palliative care would be like adding physical therapy to their clinic, or speech language pathology or social work, where we would not be billing providers, but actually the physicians and NPs can bill. And I'm hearing about a lot of MD-centric models today, and I think there's a reason for that. It's because they're easier to fund because, they can bill. And I think the social workers and spiritual care providers, unfortunately, sadly, are harder to get because they can bill. But Kelsey, I saw you come onto video. Is there something you'd like to add?
Oh, I was just I think when we first started, I got asked questions about billing pretty regularly. And I think I also was like, because you do hear so much about it, I was worried about it. And it is exactly like any other specialty provider. And so I explain that to people too, because it's also like, I don't talk with patients about billing, but I do say, palliative medicine is a specialty the same way cardiology is a specialty. We all know, they're focusing on your heart and blood vessels. Neurology is a specialty, et cetera, et cetera. My specialty is like all the parts of you that make you that we can't point to an anatomy or physiology textbook. And if people ask me specifically about billing, or when I'm talking to other providers, I will always say, like, it's billed like any other specialty care. If there's a copay when you see a cardiologist, it'd be the same for me. And then, yeah, but there is a lot of mythology out there surrounding it that I don't know why.
Yes.
Thanks. And I think about those smaller clinics, that are not university-based and things that are already struggling. At the ALS Association, we're pretty focused right now on how to keep clinics sustainable. And so if they're not educated and think this could be another cost rather than reimbursement, there just might be room to educate around that. So
I think that's a really good point, and I'd be so grateful if you could help educate, or if I can help in any way to provide that education, because certainly at UCSF, like, the physicians generate actually a little bit of a surplus that can help cover other members of the team, which is different than people of other disciplines that are a cost.
Yeah, after our conversation last week, I did reach out to some of the roundtable folks and said, is there palliative care on your, clinic sustainability roundtable discussion?
Yeah.
And I don't have an answer yet, but Kara, I know that you said, let me know if I can hop in. So
Yeah, happy to. I can
yeah.
help. Awesome. And I'm sorry, I don't know Nawaz or Dominique, or if anyone else wants to speak up, feel free. I want to make sure we're giving time and space, and Teresa too, if you'd like to, but if not, this has been a wonderful discussion. And I'm also going to send out a survey in case anyone would like to provide extra thoughts in that format. But this has been really interesting to at least me, and I hope others, and we'll continue the conversation over time.